Early assessment of acute pancreatitis dictates the entire trajectory of patient care. In the critical early hours, identifying specific physiological markers allows clinicians to accurately predict organ failure, the onset of severe complications, the necessity of intensive care, and the probability of mortality. This timeline graphic illustrates the bedside index for severity in acute pancreatitis, or the BISAP score. Note the exact application window. It is validated specifically and strictly for the first 24 hours of hospital admission. The system assigns 1 point for each of 5 parameters. The first is a specific metabolic threshold, a blood urea nitrogen, or BUN, level greater than 25 milligrams per deciliter, or 8.9 millimoles per liter. The next 2 points evaluate neurological and demographic risk. A patient receives a point for an impaired mental status, defined by a Glasgow Coma Scale score below 15, and another point if their age is over 60 years. Accumulating a total of 3 or more of any BSAP points establishes a diagnosis of severe acute pancreatitis right on day 1. The fourth parameter is the presence of systemic inflammatory response syndrome, or SIRS. To earn this single point on the BSAP scale, a patient must meet at least 2 of 4 distinct physiological subparameters. The first subparameter is a loss of temperature regulation, measured as a core body temperature falling below 36 degrees or spiking above 38 degrees Celsius. The second is a cardiovascular stress indicator, a heart rate exceeding 90 beats per minute. The third tracks respiratory distress, defined by a respiratory rate over 20 breaths per minute or a PaCO2 reading below 32 millimeters of mercury. The fourth examines white blood cell anomalies. This threshold is crossed if the total count drops below 4,000, rises above 12,000, or if a differential shows greater than 10% bands. Returning to the primary BISAP criteria, the fifth and final point is the radiographic confirmation of a pleural effusion. The combination of these vital, metabolic, and imaging indices forms a comprehensive first-day systemic risk profile. As the patient reaches the 48-hour mark, clinicians shift to evaluating the Ranson criteria. This split-screen diagram illustrates a key feature of the Ranson system. It calculates severity across 2 distinct timeframes, admission and 48 hours, and requires entirely different metrics depending on whether the pancreatitis is biliary or non-biliary. Looking at the non-biliary matrix on the left, the admission criteria begin with 2 demographic and inflammatory markers, an age over 55 and a white blood cell count exceeding 16,000. The admission baseline is completed by 3 enzymatic and metabolic thresholds: blood glucose over 200 milligrams per deciliter, lactate dehydrogenase above 350, and AST above 250. At exactly 48 hours, the second phase of data collection begins. Clinicians look for a hematocrit fall greater than 10% and a BUN rise over 5 milligrams per deciliter. Simultaneously, the criteria track critical chemical drops, including serum calcium below 8 milligrams per deciliter, a PaO2 below 60, and a base deficit exceeding 4 milliequivalents per liter. The final non-biliary parameter measured at 48 hours is profound fluid sequestration exceeding 6 liters. Together, these 11 non-biliary metrics track the rapid, profound metabolic depletion and third spacing of fluids, peaking over the first 2 days. When the etiology of the pancreatitis is gallstones, the pathophysiology changes, requiring adjusted prognostic thresholds. As seen in the right column, the biliary Ranson criteria recalibrate the limits. The demographic and inflammatory cutoffs at admission are elevated. The age parameter shifts to over 70 years, and the white blood cell count increases to over 18,000. The admission metabolic markers also require higher values: glucose over 220 and LDH over 400, while AST remains constant at over 250. Moving to the 48-hour reassessment, the biliary criteria become more sensitive to renal impairment, scoring a point for a smaller BUN rise of over 2 milligrams per deciliter, while the base deficit threshold increases to over 5 milliequivalents per liter. The fluid sequestration threshold is lowered to greater than 4 liters. Across either the biliary or non-biliary scales, a total score of 3 or higher signifies severe disease. Stratifying the Ranson criteria strictly by etiology is a necessary step. Failing to differentiate the source of the inflammation risks miscalculating the entire trajectory of the disease. An alternative assessment deployed strictly within the initial 48-hour prognostic window is the Glasgow Emery score, which evaluates 8 distinct parameters. This timeline anchors the system. The first 2 points evaluate a respiratory threshold, with PaO2 falling below 60, and a demographic threshold of age greater than 55. The systemic inflammatory marker requires a white blood cell count exceeding 15,000. The metabolic indicators measure a drop in calcium below 8 mg per deciliter and a rise in blood urea over 45 mg per deciliter that persists despite aggressive fluid resuscitation. Hepatic injury is tracked by steep enzyme thresholds, LDH above 600, or AST and ALT levels exceeding 200. The criteria list concludes with an albumin level dropping below 3.2 and blood glucose spiking above 180. Accumulating 3 or more points across any of these 8 parameters confirms severe acute pancreatitis. Unlike the bifurcated timelines of the Ranson criteria, the Glasgow-Emery system simplifies data collection to a single 48-hour block, while comprehensively integrating signals of severe hepatic and metabolic distress. As the timeline advances to the 72 to 96-hour window, clinical evaluation transitions from predicting damage via serum lab values to directly observing structural pancreatic destruction. The modified CT Severity Index quantifies this damage in 3 tiers. The first tier evaluates pancreatic inflammation. A normal pancreas scores 0. Focal inflammation or a single fluid collection scores 2. If the imaging reveals 2 or more fluid collections or the presence of gas, the score escalates to 4. The second tier assesses pancreatic necrosis. The absence of necrosis scores 0, while observing 30% or less glandular necrosis adds 2 points to the total. If the necrotic area exceeds 30% of the gland, the necrosis score hits a maximum of 4 points. The third tier applies a flat 2-point allocation for any extra pancreatic complications, which include pleural effusion, ascites, vascular complications, or gastrointestinal involvement. When tallied together, a total score of 4 or higher across these 3 categories indicates severe disease. Delaying this imaging until the 72 to 96-hour mark ensures that the structural destruction has fully demarcated, allowing clinicians to precisely quantify what the earlier metabolic panels could only infer. The culmination of this diagnostic progression is the modified Marshall scoring system. This table provides the definitive framework for assessing and quantifying active systemic failure across the respiratory, renal, and cardiovascular systems. The respiratory tier evaluates the PaO2 to FiO2 ratio. A healthy ratio over 400 maps to a score of 0, while a mild decrease between 301 and 400 maps to a score of 1. The respiratory score steps up to 2 for ratios between 201 and 300, 3 for ratios between 101 and 200, and reaches the maximum score of 4 for a profound deficit of 100 or less. The renal tier is driven by serum creatinine levels. A value below 1.5 mg per deciliter earns a score of 0, and a slight elevation to between 1.5 and 1.9 earns a score of 1. The renal score climbs to 2 for values between 2.0 and 3.5, hits 3 for values between 3.6 and 4.9, and maxes out at 4 for a serum creatinine exceeding 4.9. The final cardiovascular criteria evaluate hemodynamic stability. A systolic blood pressure over 90 scores a 0. A drop below 90 that remains responsive to fluid administration scores a 1. A score of 2 is assigned when a systolic drop below 90 is no longer responsive to fluid resuscitation. The cardiovascular score escalates to 3 when that low pressure correlates with a pH below 7.3, and hits 4 when accompanied by a severe pH drop below 7.2. A score of 2 or higher in any single organ system officially defines organ failure.